Dear Chairman, dear ladies and gentlemen, it's a great honor that I am here, and I will present my lecture is a little bit changed, how to use biomarkers for sepsis, old or new ones, and how to interpret the data. So, diagnostic algorithm for sepsis is clear. After clinical examination, we should take a blood for laboratory testing because intensive care, critical care cannot be provided without basic knowledge of values of biomarkers. Of course, then we should do microbiology and some imaging method to find a site of infection. Then we can do right decision-making process and right intervention. At the beginning, Zoli told about the huge achievement on the pathophysiology of the sepsis. And we see that in the sepsis, complement is activated, acute phase proteins are secreted, immune cells, cytokines, there is a huge release of cytokines and messenger molecules, and all these molecules can be used as a biomarkers for inflammation and sepsis. Biomarkers for sepsis are nowadays broadly used in critically ill patients. Zsolt and János were the first 25 years ago to introduce and establish procalcitonin in the Hungary. Also in the Slovakia we did. And nowadays we used regularly PCT, CRP, interleukin-6, neutrophil lymphocyte ratio, lactate in regularly clinical practice on our ICUs. The trend is, you see here on the new one, there are a lot of new parameters like neutrophil CD64, SCD14, presepsin, and other signs on the immune cells. But the most perspective, it seems to be endocrine response like NT-proBNP as a marker of cardiocirculatory failure and proadrenomedulin. How to use biomarkers for sepsis? It is built on research and on clinical experiences. We should not use one or two, one standard, but we should use a panel of validated parameters for inflammation and sepsis. We should do not only on admission, but we should repeat it in serial measurements in time. And then we can estimate kinetics of each biomarker. Biomarkers can be used even for prediction and prognostication of critically ill patients. And there are some issues on how to evaluate the intensity of immune inflammatory response, because there are three types: hyperreactivity, accurate immune response, and hyporeactivity. Sepsis is a complex dynamic syndrome with high variability of signs and symptoms. We know that nowadays are also recognized sepsis endotypes: hyperinflammatory, coagulopathic, adaptive. Each case of sepsis is unique, and you see how many factors influence on the sepsis heterogeneity: genotype, phenotype, innate state of immunity, organ reserve, and the big impact, of course, have etiology, microorganism, whether it is bacteria, gram-positive, gram-negative, fungi, viruses, or parasites, and each of these subgroups may induce different pattern of humoral cytokine and acute phase protein response. These biomarkers are mainly used in the Bratislava University Hospital, as we are using PCT, CRP, NT-proBNP, neutrophil lymphocyte ratio, and of course, lactate. Also, complete blood count may be very useful to diagnose septic shock. We should not use very expensive biomarkers, time-consuming, and which are doing twice a week or once a week, but even complete blood count carries very big information about immune response and about sepsis. You see the paper by Joshua Farkas, and he cited a paper by Gurol. Yes, they compare procalcitonin, C-reactive protein, and the values of neutrophil lymphocyte ratio, how they are associated and correlate in 1,400 patients with sepsis. It was a study in Turkey. Biomarkers can be used also as prognostic predictors and therapeutic guide in critically ill patients. You see how many biomarkers are here. Some are well known and used. There are also the new one. And as you see here, there are also procalcitonin, proadrenomedulin, anti-probin P, but the new one are pancreatic stone protein or dipeptidyl peptidase 3. SUPAR is well known 10, 15 years. All of this can be used to measure and to follow up during the course of sepsis. However, the main host response biomarkers we are using in routine practice in critically ill patients stay CRP and procalcitonin. You see that there is hormokine, procalcitonin, these acute phase protein, all qualities, all properties. There are hundreds of papers. Which one is better to monitor and to diagnose sepsis and septic shock? We can say that it is nowadays 50 to 50%, and we should use both because they are complementary. Nothing is better. Maybe PCT is much better in the early phase of sepsis due to the kinetics of procalcitonin, but in subacute or chronic states, the C-reactive protein have a big privilege against procalcitonin. So this is a nice paper, yes, done by EPROC study. So thank you to all of this. It is a Hungary study, the kinetics of procalcitonin, how much it is important in the very early state after admission to the ICU to measure every 8 hours. So it is real fascinating results, and you can see that the group of patients with appropriate antibiotic therapy after 24 hours had significantly lower PCT concentration than patients with inappropriate antibiotic therapy. And also the kinetics is important. You see in the good outcome, the decline of PCT concentration in the next days. Also, PCT is able to differentiate between medical cohort of patients and surgical. You see the big differences in the concentration of procalcitonin. So, as I mentioned, the new perspective to use in our ICUs is anti-probin P. It was used in heart failure, acute, chronic heart failure. It was privileged to cardiology, acute cardiology, intensive cardiology. Nowadays, we know that it is very useful even as a prognostic factor for septic shock patient presenting to the emergency department and in the ICU. And you see that they compare it together with lactate, anti-probin P, their cutoff values associated with high mortality together with procalcitonin and C-reactive protein. So here are the same paper, and you see that for prediction of the death, the best was the combination of lactate and anti-probin P. Reliable, valid biomarkers for sepsis in our ICU, as I told, are these 5 or 7 biomarkers written here, and they are representing different processes, different groups. For example, lactate, anti-probin, endocrine system, immune parameters, PCT and interleukin 6, acute phase protein, CRP and albumin. So these are very, very useful and reliable in everyday clinical practice. So neutrophil lymphocyte ratio can be also used to predict the outcome of the patient, to follow up in the few days, in the day 1, day 3, and day 7, may differ between mild and moderate course and severe and critical course. the blue one. And also you can see the trend. The higher trend, there is bad outcome of the patient. The same, the time course of risk factors associated with mortality. In a very robust study from Italy, the patients suffer from COVID-19 pandemic. Even you see the neutrophil lymphocyte ratio in survivors decline in the first 30 days during ICU stay or hospital stay, and neutrophil lymphocyte count is going up in non-survivors. CRP, the same, the good outcome decline, and in death, non-survivors, it's going up. Now, please, I would like to turn your attention to the maximal values, peak values of interleukin-6 and PCT in hemato-oncological patients with sepsis. This is from one study, 2019, and you see here alive patient, the distribution of maximal interleukin-6 value, and there are values of the dead patients. So it is clear, very high values, above 1,000 picogram per milliliter, but I would like to turn your attention that some small group were values very low, in normal values. The same situation in PCT, alive, survived patient with septic shock. The distribution, of course, the death with very high values, but even there's small amount of the patients who were low procalcitonin concentration. The same and very similar observation was done by French researchers, leading by Florence Richet in 2015, and they observed that ICU patients with septic shock with a low neutrophil lymphocyte ratio at admission died in the first 3 days. It's something like paradox. And this observation was observed in Korean study, neutrophil lymphocyte ratio as a prognostic marker in critically ill septic patient. It was very huge, 1,300 patients, divided according to neutrophil values to 5 groups. And you see that the highest mortality rate, yes, here is this part, the group with persistently low neutrophil lymphocyte ratio and persistently high neutrophil lymphocyte ratio. So this is a quintile 1 and quintile 5 divided according neutrophil lymphocyte ratio quintiles. And finally, very recently, 2-3 weeks ago, the Chinese issued the effects of C-reactive protein trajectories of critically ill patients with sepsis and its impact on in-hospital mortality rate. They used special statistics, and they divided the patients in the first 4-5 days on ICU and the values of CRP. So this is a class 3 with very high CRP values, around 200 milligrams. Group class 4, class 1, yes, is here. Class 2, such a course in the first 5 days, and class 4. Class 4, the CRP is a paradox low, about 50 milligram per liter. You can estimate in which class will be the highest mortality, in the highest CRP, and on the second, the lowest. The same like neutrophil lymphocyte ratio. So we can estimate that at least there are hyperreactivity or high immune inflammatory response is this group, high mortality. On the second place, high mortality was in the patient with a low CRP, and the best survival had the patient in the middle, the class 1. High CRP, but be around 100. And after third day, there is a decline of the values. So in conclusion, how to use biomarkers for sepsis? Some tips and tricks. Use a panel of different markers. These 4 we suggested, but it depends on each ICU. We should monitor even the shock, not only with lactate, but even use NT-proBNP to measure intensity of immune inflammatory response. use a valid, reliable laboratory markers which are available on daily basis 24/7. Serial measurements of biomarkers may be used to follow up kinetics, and you should follow up the trends, increase or decrease, like in the APROC study in PCT, but it also works in neutrophil lymphocyte ratio and in C-reactive protein. Then also follow up the delta, and you can evaluate the patient outcome. In the future, will be more and more used the ratios of markers here, not only neutrophil lymphocyte ratio, but even, for example, CIP, albumin ratio, neutrophil to albumin ratio. There are some indexes, and there is also recommended to use SOFA together with biomarkers. And at the end, of course, evaluate sepsis biomarkers only with regard to the clinical status and clinical context, not isolated, but it can be very useful and helpful for you in decision-making process. Thank you so much for your attention.